see. Let's see. Hopefully I can edit it.
They edit you out walking?
Okay. Huh?
I said edit you walking back from turning it on and all
Yeah,
that
that's
stuff?
what I'm saying, because...
Wasn't you able to edit it? Did you able to edit it?
I didn't edit,
also?
girl. You know, we don't have a certain amount of time. I had to go and get that together.
Oh, is it recorded now?
Yeah.
Oh.
But I'm going to try to cut that out.
Do I have to, is there anything to read?
No, but I'm going to ask you a question.
Okay.
Okay?
That's
All right. Implementation of a catheter care bundle and increased compliance with current clinical practice guidelines, I know it's a lot, to reduce catheter-associated urinary tract infection. By myself, Nikita Burton. So, I'll kind of let you all read the abstract. I guess I can read it to you. Catheter-associated urinary tract infections result in increased morbidity, mortality, length of stay, and increased healthcare costs. The senior project will define CAUTIs, explain why changes needed to reduce CAUTIs, and use evidence from best practice guidelines to answer a PICO question and identify current practices being used. Assess compliance with policies and evaluate CAUTIs after successful implementation of guidelines. So, what is the problem? So the problem is catheter-associated urinary tract infections. So it is very common that we see once nurses arrive at work that patients have a urinary catheter in place, especially for our unit, because we're an orthopedic surgical unit. So most of our patients come from PACU with urinary catheters in place. So according to the CDC, 15 to 20% of patients in hospitals receive urinary catheters. And the definition of a catheter is the presence of a urinary tract infection after a patient has had a urinary catheter in place for greater than 2 days. So why should a change be made? Catheter-associated urinary tract infections are the fourth most common infection that's acquired in hospitals, or the equivalent of 30% of infections that's acquired in hospitals. Increase the length of stay for 2 to 4 days. So for a patient, say, that had a total hip replacement, they normally stay for like 2 to 3 days. So as opposed to 2 to 3 days, they may stay for 5 to 7 days as opposed to 2 to 3. Approximately 30,000 deaths a year, and CAUTIs are responsible for greater than $560,000 in healthcare costs a year, according to Gould. So, other changes, that needs to be made is because CAUTIs compromise patient comfort and also safety. They increase the risk of morbidity and increase complications for men and women for cystitis and prostatitis. That's inflammation of the bladder and the prostate. Also, it can increase the risk for kidney infections and reduce the effectiveness of nursing care. So the objectives of this senior project is to increase the awareness of the problems of CAUTIs, assess the knowledge and compliance with current policies, inform healthcare professionals of best practice guidelines to reduce CAUTIs, and identify ways to implement best practice guidelines into nursing care practice. So what is the root cause of CAUTIs? So you all are familiar with nursing care practice. So what have you seen in practice that have increased the risk for catheter-associated urinary tract infections?
Improper pedicare when people have on catheters.
Okay, pedicare. Jen?
Tubing not being flowing adequately, having loops and kinks in the tubing, which can lead to urine backing up in the bladder.
Okay.
Yeah.
So both of those are correct. we're just going to go over some causes, some root causes of catheter-associated urinary tract infections. So hand hygiene. Proper hand hygiene is a must, because if you don't follow proper hand hygiene, you risk introducing bacteria into the patient. So next we have the stat lock. It is all too common that patients come to the floor, they don't have a stat lock, the tubing is just, flopping around, and at risk the tubing being dislodged from the urinary meatus, and that can introduce bacteria into the patient as well, especially if the patient needs the urinary catheter, and that can risk introducing bacteria into the patient if you have to reinsert the Foley, especially if initially you do not use proper hand hygiene. So, and the next cause for risk of catheter-associated urinary tract infections is if the Foley catheter bag is on the floor. That increases the risk for bacteria being introduced into the Foley bag and travel up the tubing of the catheter, and then that's how it's introduced into the patient from there as well. So this is another common thing we see on the floor as well. When the catheter tubing is kinked, it may not be tied in this way, but it may be kinked at any area below or above the level of the bladder. So this can impede the urinary flow. So stagnant urine increase the risk for catheter-associated urinary tract infection and increased urinary retention. So, and Jessica, what you said about proper peritoneal care, this is one of the things we use for cleaning the peritoneal area to reduce the introduction of bacteria into the patient. Especially if they're having like loose stools and they're not being cleaned properly, the bacteria can be introduced that way as well. So, and like I said, our floor is an orthopedic floor, so many of our patients are being transferred, either ambulating in the hallway, wheelchairs, or from stretcher to bed, and it's easily for a patient to be transferred and the catheter bag is not at the level of the bladder, because it should be below to increase the steady flow of urine to prevent obstruction. So it's not always at times when the catheter bag is at below the level of the bladder, which it should be, to reduce the catheter-associated urinary tract infections. So my PICO question is, does implementing a catheter care bundle and or increasing compliance with current clinical practice guidelines reduce the number of catheter-associated urinary tract infections in hospitalized adult patients requiring an indwelling urinary catheter? So for the patient population, it's the hospitalized adult patients that's requiring a catheter. The intervention will be implementing a catheter care bundle and increasing the compliance with current clinical practice guidelines. And of course, the outcome will be to reduce the number of catheter-associated urinary tract infections. So why do we need a change? The evidence for change would be that the number of incidents of catheter-associated urinary tract infections are increased on all floors, and also a report is generated by the National Healthcare Safety Network or by our epidemiology surveyor, Victor, as we know him on our floor. He comes to each of the floors and let us know how many healthcare acquired infections that we have, such as CAUTIs or MRSA. And the lack of proper technique by nurses, because when I went to investigate how nurses develop the number of catheters per floor, the risk for catheter-associated urinary tract infections, and how they're what they're doing to improve it, what I found out is that a lot of the nurses don't know how to locate the protocol or don't know what the protocol entails. So that would be a lack of education by the nurses and techs. And also, nurses are not properly documenting when the catheter was inserted or removed, so they're not really going by the skip protocol if they're on the surgical floor, or going by the clinical practice guidelines. And according to Gould, 50% of hospitals do not effectively monitor the presence of catheters. So, how do we correct the problem? So my recommendations for change would be to educate the patients and the staff, of course, of where the policy is. And for St. Francis, it will be under the resource tab, under the intranet, and it will be Compliance 360, and educate the patients of the contents of the policies. And in this case, we can also ask the clinical nurse educator who is responsible for uploading system-wide educational and training for St. Francis, as opposed to the health stream that we have to do. That can be uploaded there for all the nurses. They can go and review that content in there. And also, the technique for catheter insertion and care needs to be reevaluated, and not just for the annual competencies, because that's yearly, so that can be too long, especially if we're dealing with the catheter-associated urinary tract infections on a daily or weekly basis. That needs to be reevaluated. And according to the National Guideline Clearinghouse, 20% to 69% of CAUTIs can be prevented if nurses and staff just follow the clinical practice guidelines. So, and what I propose will happen after these recommendations is an improvement in patient outcomes and a decrease in the number of CAUTIs. So the current policies, like I said earlier, that nurses need to familiarize themselves with the current practices and the policies, and these are located in Compliance 360 on the St. Francis intranet. And I have a copy of the current bladder regimen policy for St. Francis. And I'll just go over some of the important details of it. The goal is to prevent the use of some of the urinary bladder catheters, because some patients are required to have it per their disease process, and that urinary catheters should be assessed daily for their clinical necessity. And this particular policy that St. Francis has, it is in accordance with the AHQR, which is the Agency for Healthcare Quality Research Guidelines. One of the topics for the bladder regimen is for catheter avoidance. And what this means is that nurses or the techs make available to the patients that they have a bedside commode or a bedpan and straight catheter and bladder scan, as opposed to inserting a urinary catheter for long periods of time. And also there's indications for insertion and maintenance of the catheter. So if a patient requires IV pressors or fluids, or blood pressure or cerebral perfusion pressure, then a Foley is indicated. But per our floor, that's not necessary for any of our patients, so that won't apply to our floor. But for other floors, a Foley catheter will be indicated. And on the next topic, the spinal surgery or thoracic lumbar injuries, this applies to females only. A Foley catheter will be indicated as well. But I see it happen, such as in the ER, where some of the nurses there insert Foley catheters for a patient with incontinence. And it's not required for a patient with incontinence unless a patient has a decubitus ulcer that is healing. So that will be the guideline for insertion and maintenance of a urinary catheter. And also, we need to increase compliance with the policies and surveillance tools. And this tool should be on every floor, because every floor that requires a patient to have a catheter, it's just a series of yes and no questions asking, first, is there a clinical reason for catheterization of a patient, and is it necessary? Yes or no. And a person inserted the catheter, have they been trained? And has education been given or provided and documented? Has the securement device been utilized, such as the stat lock, that is sometimes not present on patients when they arrive to the floor? If the drainage bag is below the level of the bladder, and is the system a closed system and the seal has not been broken. So that red seal that's right below the where the stat lock should be, if that's broken, that breaks that closed system, that increases the risk for infection. And the bag, is it overfilled? Because if it's more than it shouldn't be more than 2/3 of the way filled. So this should be on all of the floors to assess whether a patient needs a urinary catheter. So what are the best practice guidelines for urinary catheters? Well, the Joint Commission, they have national patient safety goals, and in particular, goal number 7, it states to reduce the risk of healthcare associated infections, and specifically goal 7.6.1, it's implementing ways for evidence-based practice to be used to prevent catheter-associated urinary tract infections. And the Joint Commission says that healthcare acquired infections are a patient safety issue, and that the incidents are acquiring more at an alarming rate, and that the best way to prevent them is to educate the staff and to use aseptic techniques when preparing the site, the equipment, and the supplies, and making sure that you're securing the catheters for unobstructed urinary flow and maintaining the sterility of the urine in the collection system. So also, next, the National Guideline Clearinghouse says that we should use catheter avoidance, which is the use of the bedpans and the bedside commodes if the patient does not require catheter in routine care, such as the peritoneal care. And also participation in quality improvement programs, such as the surveillance tool that should be on each floor to assess the necessity of catheters, making sure we're educating the employees and the patients, and indication for catheters, whether or not they need to be inserted or removing them as soon as possible, such as with the skip sheet. And also maintenance of a closed drainage system and hand hygiene. So evaluation of a project, nurse leaders should frequently quiz the staff and making sure that they evaluate the knowledge that staff are aware of the policies and procedures for catheters. Check the catheter log daily. Now we have daily huddles, usually at shift change, and that's a way that we, at a time where we can evaluate compliance of all of these procedures. And also nurse leaders can check to make sure that we're doing routine care of catheters, doing the grand round, so when they're checking the rounding sheets, making sure that the patient is getting the care that they need. They can assess whether or not the catheter is below the level of the bladder, it's not kinked, they have the stat lock in place. Also enforce compliance with catheter removal times, such as with the skip sheets, and making sure that the nurses are doing their 12 and 24-hour chart checks, and making sure that the Foley catheters are removed on a timely basis.